Our next speaker is a preeminent scholar and academic. Dr. Karim Ladha is an anesthesiologist and clinician scientist at the University of Toronto. He received his undergraduate degree in economics from Brown University and obtained his medical degree from Johns Hopkins University School of Medicine. He then did his residency at Mass General Hospital, did additional fellowship training in cardiac anesthesia here at TGH. Dr. Ladha heads a diverse research program and conducts innovative studies in several areas, including acute and chronic pain, the use of anesthetic interventions to target mental health conditions, and the impact of psychosocial factors in perioperative medicine. He's been awarded, I'm not going to go into the amount, Karim, but millions of dollars in funding from numerous agencies, CIHR, Patient-Centered Outcomes Research Institute. He's also been awarded several awards, including Career Scientist Award from the Canadian Anesthesiologist Society, the International Anesthesia Research Society's Mentored Research Award, and the Impact Award in Anesthesia. He's published over 130 manuscripts in high-impact journals like JAMA, BMJ, Annals of Internal Medicine. And his research has also been covered in both national and international media, including CNN, the LA Times, the Globe and Mail, and Nature. Dr. Ladha is going to be talking on cannabis for chronic pain, current evidence, and next steps. Dr. Ladha, please come up. Thank you.
Thanks so much, Joel. I like to refer to Joel as the godfather of the TPS, and so it's truly an honor to be speaking here today. And when I look across this room, I see so many people who have mentored me and been my colleagues and helped me on this journey, and so I feel truly privileged to be able to be speaking to you today. So I've been asked to speak about cannabis, but this talk is also about evidence and the bias with which we place on the evidence that we have to date when we treat our patients with chronic pain. A few disclosures, I was co-PI of an observational study that looked at medical cannabis that was previously funded by Shoppers Drug Mart. I do want to acknowledge the Evelyn Bateman Recipe Chair at Women's College Hospital for supporting my time outside of the operating room. So, Tara did an excellent job talking about the opioid toxicity crisis and the nuances. And she even mentioned that this is how we typically start, with this oversimplified version of someone holding pills when we talk about opioids. But of course, we know that this is more nuanced. And so this is a headline from the New York Times that I like. It says, "Good news, opioid prescribing fell. The bad, pain patients suffer, doctors say." And pain clinicians have really been put in the middle. On the one hand, what we want to do is mitigate suffering and improve outcomes. But on the other, we have these really real consequences of opioids, such as misuse and diversion, which you've heard about today. And so with that, let's talk about the alternatives. Right? Gabapentin, if you've ever practiced chronic pain, is a drug that we all know well. It's used for neuropathic pain. When you look at guidelines from the Canadians, it says it's first line to be used for neuropathic pain. In fact, when they did a systematic review of guidelines, numerous organizations have repeatedly said that gabapentin should be one of the first line agents for neuropathic pain. With this, when people are looking for alternatives to opioids, a lot were switched to gabapentin. Made sense. That's what the guidelines said we should do. But in reality, if you actually look at the evidence and what the marketing was around gabapentin, it was oversold. Truth was that if you looked at the randomized controlled trials, most said that the drugs were either ineffective or only modestly effective for many of the off-label indications. So within this context of looking for something else, cannabis comes up. Now, I always like to start a cannabis talk by saying, what are we talking about? And cannabis goes by lots of different words and terms, such as hashish, marijuana, but in the scientific community and as clinicians, we should use the words cannabis because that is the genus of the plant that we are using. So, cannabis actually exists in our body in some form. We have an endocannabinoid system. We have receptors, CB1 and CB2, which are found throughout the body. But that's probably an oversimplification because we know that cannabis acts on various receptors. And if you look at the bottom there, opioid, NMDA, GABA, as anesthesiologists and pain physicians, those are receptors that we like, that we want to target for pain. Furthermore, there are two main compounds in cannabis, THC, which works on the CB1 and CB2 receptors. We think it might be responsible for therapeutic effects. It also causes the psychoactive effects. CBD, we don't actually know how it works. If you listen to Hans, he'll often use this term allosteric modulator. I've been hearing him say that for years. I still don't really know what it means. But it's thought to have these anti-inflammatory effects and it may improve the tolerability of THC. Now, there is some biologic plausibility for cannabis working in pain. And I apologize to any of the basic scientists in the room who may cringe because this is a gross oversimplification. As you heard, I was an economics major, and so science sort of eludes me sometimes when it comes to molecules and receptors. So we know that cannabis works at multiple levels, it can work at multiple receptors, and it can have multiple components which theoretically can affect these things. And so there's lots of basic science evidence to suggest that cannabis may be useful for pain. So with that, where does the clinical evidence lead us? What does it tell us that we should do or advise our patients who are coming to us to ask us, should I use cannabis for my chronic pain condition? And so the first thing that we look is this article or this survey that says, well, most patients use medical cannabis for chronic pain. Now that tells us something, right? That's what our patients are saying. Well, I'm using cannabis and this is helping us. But when we look at evidence, we often put anecdotes or clinician or expert opinion at the bottom of this pyramid. At the top, we have systematic reviews, the pinnacle of evidence, the highest form of what we should be listening to, right? Well, let's look at what the systematic reviews say. Well, when we think about evidence, this is what we want our systematic reviews to say. We want us to tell us whether cannabis is good or bad, done, yes or no. In reality, evidence often looks like this. There are more questions that come up than answers. And so the first question that people often ask is, does cannabis reduce opioid use? And so here's a systematic review from a group at McMaster. This is great. So what they said is they looked at randomized controlled trials that looked at opioid use in cannabis, and what they found was that all randomized controlled trials instructed patients to maintain their opioid dose. Doesn't really tell us much, does it? If you're telling someone to stay on the same dose, how could we make any inferences on whether cannabis use makes a difference? The next question that comes up was, does cannabis reduce pain intensity? And so here is where things get a little complicated. That's when two people can look at the same thing and come up with a different conclusion. And so this is a tale of two systematic reviews. The first is from NICE, which is an organization in the UK, the National Institute for Health Care and Excellence, who did this review. And for those that aren't familiar, this is a forest plot. You take evidence from different studies and you pull them together. And the number to pay attention to is the one at the bottom, which showed an effect of 0.44. So for those of you who don't know, an important difference is 1, right? And so this is less than an important difference. And so what they said was, well, cannabis made a difference, but it's less than 1. Now, we have another systematic review, again from McMaster. The second author, Patrick Hong, is actually going to be starting his pain medicine residency with us in Toronto. They did a systematic review, same topic, but completely different methodology. And what they found, again, with that number on the bottom, was minus 0.5. Again, suggesting that cannabis made a difference, but it wasn't statistically or meaningfully different. Now, this is reassuring in a lot of ways, right? Two groups did systematic reviews, completely different methodologies, and they came up with basically the same effect size. Phew. All right, science works. The thing is, when they actually came to the end of the paper and the conclusion, they said different things. So on the one hand, NICE said, do not offer the following to manage chronic pain in adults. Nabilone, which is synthetic THC, dronabinol, we don't have in Canada, THC or CBD. The McMaster group came with a much more complicated and nuanced conclusion. Compared with placebo, non-inhaled medical cannabis probably results in a small increase. I'm not going to read the end of it. But what they did say, to summarize, is if standard care is not sufficient, we suggest offering a trial of non-inhaled medical cannabis. Okay, so I want to just go over what systematic reviews tell us. And so when we think of any intervention, there are 3 possible outcomes on a very simplified level. The first is someone gets better. The second is someone gets worse. And the third is that someone stays the same, there's no difference. And so let's take two studies where we have two cohorts of patients. They have a mean pain score of 7. We give them two different types of cannabis. On top, the cannabis makes half the group better. On the bottom, the cannabis makes half the group worse. The other half of the population stays the same. We do this meta-analysis, which we think we're combining studies, increasing our power, and we come to the conclusion that cannabis doesn't work. The mean pain score is 7. And so that's fine when we do epidemiology or we do policy and we want to think of populations. But as clinicians, what we actually care about is the individual. Who is this one patient that is going to benefit from cannabis? Which one of the individuals sitting in front of us in our chronic pain clinic is going to get better because of our intervention? And unfortunately, we can't say that. And so this is a cliched statement that more research is needed. But when you think about cannabis, there's a lot more that we need to figure out. So on the one hand, we need to learn more about cannabis itself. We often think of it as this monolithic agent, but in reality, there's lots of different things in terms of formulation, method of administration, dose and frequency. We also need to know more about the patients that we give it to. Who will benefit in terms of their indication, psychosocial factors, biologic factors. And so how do we go about figuring this out? So we need more trials. And these are two examples of studies that have been done just in the last year or two. And I think this is an important first step. So the first is a paper published in The Lancet about oral CBD for osteoarthritis. They gave patients about 600 milligrams of CBD for osteoarthritis, and they found no difference. Now, Hans, myself, Mickey, and Sarah, who are all in the audience today, wrote a letter to the editor about this. So this trial actually only randomized 58 patients, much less because they had a huge dropout and couldn't analyze more than that. They didn't actually titrate a dose, and they had large dropouts because patients couldn't tolerate this. The second trial is related to neuropathic pain. Again, it was about an 80-patient study with 4 arms, meaning only 20 patients had each intervention. Now, with that kind of sample size and what we know with the heterogeneity in pain patients, there's no way that you can make any inferences from these studies. But the problem is now people are losing hope. And so this is something called the Gartner hype cycle. It's often used to explain apps or new technologies in Silicon Valley, but it actually applies to pain interventions as well. And so when you think of where cannabis was 5 years ago, we were at the peak of inflated expectations. Right now, I think with the evidence, people are at the trough of disillusionment. And so what we are trying to do in TPS and through our research is bring us to the slope of enlightenment, to a plateau of productivity, where this will have some sort of rational way to help patients with their chronic pain. And so the way we're doing that, first we have a pilot randomized controlled trial. We are taking individuals with chronic pain who come to TPS. We have a target enrollment of 51 patients. Now that is an important number because remember, this is a pilot study. So our pilot is 51 patients, which is larger than the randomized controlled trials that have been published to date. We have 12 weeks of treatments in 1 of 3 arms, CBD to THC, a smaller ratio plus placebo. And the primary outcome of this is feasibility. We're not going to make any assertions of effect, but we will explore those outcomes of opioid dose and pain interference for these patients as well. Recruitment is ongoing for this trial. We hope to have it done soon. Maybe at the next anniversary, 10 years from now, we'll have results to share with you. The other thing is this trial. And so Hans showed this slide earlier. I'm going to show it again because I think this is really important, and I think it really speaks to what TPS can do as a foundation to drive research and innovation. And so when I showed you that slide that said more research is needed, there are lots of questions that are unanswered. And no matter how many randomized controlled trials we do, it's going to be hard to figure out quickly who is benefiting from which type of product. So instead of running a trial, what we can do is actually leverage the patients that we have and take their data to figure out what's going to be best and who works for, or what works for whom. And so the way we do this is we take patients who are in the clinic who are going to start cannabis, and we enroll them in the study to track them over time. We don't necessarily direct them in which direction to go. It's very pragmatic, But we get this real-world evidence, and from that, we can rapidly get data in a way that we can never do in a randomized controlled trial to figure out who is going to benefit. So the thing is, these studies are great, and like I said, maybe 10 years from now we'll have the answer, but the reality is our patients who come to us are suffering now, and we need to figure out something now. And so for any patient, what we want to do is have a conversation of risks and benefits. And I think when we talk about the TPS, and something that Hans has always taught me when I was training, was that we have to meet people where they are and treat them as human beings. And so when we think about cannabis, it's not simply about the evidence, but it's about someone's journey with their pain and what we can do to potentially make it better. I think one of the most challenging things about prescribing or authorizing cannabis for someone's chronic pain is the cost. And when we look at evidence, people say, well, we can't reimburse this because there's no evidence behind it. Well, I want to share with you an example, another example of evidence or lack thereof of stuff we do every day. So this is a paper, and I think almost everybody on this paper is here in this audience today, where we looked at nerve block injections for chronic pain in Ontario. And when you look, we saw this tremendous increase. There was about a 3-fold increase over almost a 10-year period in the number of nerve block injections occurring. And so we use administrative data to figure this out. And we can't know whether patients are actually benefiting from these or suffering harm. But we wanted to do a little bit of a deeper dive. And so we published a follow-up. And we wanted to look at who is actually doing these injections. And so we did this Lorenz curve. You're going to have to actually talk to Tara if you really want methodological details on this, because she's the expert. But basically, if every provider in Ontario did an equal number of injections, the line would be close to that 45-degree intersecting the graph. But what we found is that a small handful of physicians who did not have any subspecialty training in pain were doing injections. And they weren't just doing one injection. They were doing dozens, sometimes hundreds of injections on a single patient. And we have no problem funding this. And I think one of the things that saddens me about our healthcare system is that we take things that we know, like TPS, which has psychotherapy, acupuncture, physical therapy, things that we know to benefit that aren't covered, that patients can't access. But when it comes to nerve block injections, we're happy to fit the bill. And I think that gives us pause, and one of the reasons why I love this room here today is because we all know this, and if we continue to fight, then maybe this will change in the future. So in conclusion, strong evidence to support any chronic pain medication or intervention, including cannabis, is generally lacking. We need pragmatic trials and prospective studies, and the decision on the use of cannabis should be determined by patient circumstances. This is an acknowledgement to Carf, Stewart, McCluskey, who many of you know, asked me to put this slide up. They've supported my research for a long time. If you're interested in donating, he just fixed the QR code yesterday. But if any of you see him, you can say I did actually put this slide up. Thank you very much. Happy to take questions or chat after.